should have started this first. Okay, so 25 is all about body fluids and how things work in the body. So you got some types of fluid that you need to be aware of: the intercellular, extracellular, interstitial, and plasma. So intercellular is fluids inside the cell. That's pretty easy. Just remember intracellular. So extracellular means outside the cell. Extra, out, inter, in.
Are we still doing our lab today?
If you haven't finished it, yeah. I started putting stuff away though.
There's no extracellular on this one.
That I'm doing the silver bottles. So. Okay, so interstitial. This is the fluid that surrounds individual tissues. So some of this you can do on this. It's not going to follow everything that's on the preview review. But these are things that you should know what they are. And plasma is the liquid portion of whole blood. Okay, so these are considered bodily fluids. Covers everything, right? We okay to go forward? Not yet? I heard yes and no.
So how many labs are we going to have in this section? Is it?
So
I don't know, however many.
Four?
when
Something
you're
like
storing blood, you have your blood, and then your cells are in the plasma, which is like.
So you have red blood cells and white blood cells, and
So all your cells are inside the plasma, and both those combine.
right, to make your blood. Yep. Okay, so here we have a little pretty picture. So inside of your blood, like he was just telling, we have red blood cells, we have platelets, we have white blood cells, and we have the plasma that they're all running around in. Okay? So, as we're using different parts of our body, for instance, lungs, in our blood plasma, it helps move oxygen and CO2 around. Our interstitial fluids also move oxygen and CO2 around to our intracellular fluid tissues. Our gastrointestinal tract moves nutrients and water and ions back and forth. And our kidneys move water, ions, and nitrogen waste. Okay?
So what happens if you only have one kidney?
What? I didn't hear you, sorry.
What happens if you only have one kidney?
Then that kidney has to take over. You can still live on one kidney. Okay, so we're going to watch the Bozeman thing real quickly. Hopefully it'll work. There we go.
Hi, it's Mr. Anderson, and in this video I'm going to talk about interstitial fluid. Interstitial fluid is a term that confuses students. If you ask them what is a capillary, they know that, they know what's in blood, they know what cells are, and the tissues are made up of cells. But if you ask them what interstitial fluid is, they're confused. And that's too bad, because that's going to be found between the capillary and the cells. And so
Oops, sorry.
what is it like, or what does it look like? Well, think about this. This doctor right here is doing arthroscopic surgery on a shoulder. And so how does that work? You've maybe seen videos of that. Well, they put a camera in, and then they're going to introduce fluid in there. But basically, what does it look like inside our body? If you take a camera and put it inside our body, it's not just blood everywhere. The blood is going to be confined to the blood vessels, but there's still going to be fluid inside our body. And what is that fluid? That fluid is called interstitial fluid. And so really, it's going to be what separates all of our cells from the circulatory system. Since we have a closed circulatory system, that means that the blood is going to be maintained within these vessels the whole way around the loops. But how does the material get out of the blood and eventually get into our cells? It goes through the interstitial fluid. And so if you visualize it like this, it's a fluid on the inside of our body that surrounds all the cells, then you're getting there. And so there's microcirculation that takes place at the level of the capillary. And so as the blood is flowing away from the heart, it'll work its way down eventually to the capillary. And what holds the pressure inside a capillary? Well, there's going to be hydrostatic pressure. Hydrostatic pressure is going to be the pressure out on the capillary. It's pushing out. if you want to get an idea of what that really is, what is that hydrostatic pressure? Well, if you were young and you played with a hose when you're having a water fight, if you could ever get a hold of the hose and you put your finger on the front of it, you could increase that pressure and squirt it farther. And so that pressure on the inside of the capillary out on that fluid is going to be hydrostatic pressure, and that's going to move fluid outside of the capillary into the interstitial fluid around it. There's also going to be osmotic pressure. What's osmotic pressure? That's going to be water flowing in because we're going to have a higher solute concentration on the inside. So the combination of these two pressures, hydrostatic and then osmotic pressure, is going to create that blood pressure on the inside of our vessels. Again, it's going to be probably greater hydrostatic pressure on the capillary or on the artery side and less on the venule side. Where does the water go, though? When it leaks out, what's going to happen to this water or this fluid as it moves out? Eventually, it's going to move into what are called lymph vessels, and those lymph vessels will return that fluid to the blood. And so the major parts of the blood stay within the capillary, but the fluid is going to move between the two. And so I put together this little diagram to show you that. And so this is a capillary. So the capillary is going to be, if I were to ask you what it's made up of, the capillary itself is going to be made up of cells. And so the surrounding of the capillary, or that tube of the capillary, is going to be made up of endothelial cells. So it's going to be these really thin cells. What's on the inside then of our capillary? This is going to be plasma on the inside, and then we're going to have these red blood cells. We also have platelets in here, and we're going to have white blood cells as well. But if we're just talking about interstitial fluid, this plasma on the inside of our blood is very similar to the interstitial fluid. And so what's going to be in the interstitial fluid? Well, there's going to be a lot of water, but we're also going to have sugar, salt, hormones, neurotransmitters, carbon dioxide, oxygen. And so it serves as a conduit between the capillary and the tissues itself. And so what's a gas that the cells are going to consume? They're going to consume oxygen. How does it get there? Well, it's going to be consumed here in the mitochondria, but it's going to diffuse from the red blood cells through the plasma, through the interstitial fluid, and it's eventually going to move here. What's going to happen to the carbon dioxide? It's going to build up inside the mitochondria. It's going to diffuse out. It's going to diffuse through the interstitial fluid. It's going to diffuse through here, and it's going to be carried as bicarbonate on the red blood cells. And so really inside our body, what do we have? We have cells, and so red blood cells, the lining of the capillary cells, and then clearly all the cells that make up our tissues, and then we're going to have fluids. And really that's it. That's about the two things that we have. We're going to have some things obviously that are matrix made up from material that are produced by cells. But the interstitial, you can see, is very important, that interstitial fluid, because it's going to be what surrounds our cells, and it's going to be how nutrients get from the blood into our cells and waste products get back. That's interstitial fluid. It's clear. If you really want to know what it looks like, well, think about the plasma inside blood, and that's essentially the same thing. And I hope that's helpful.
Okay, so I'm going to come back out here. And the average adult contains about 42 liters of fluid, 12 liters of intercellular fluid, 4.5 liters of extracellular fluid, and 1.5 liters of blood volume. So you can sort of see overall, intercellular fluid is the biggest, then interstitial. As we go forward, we have 3 columns with body fluid electrolytes, and electrolytes become very important. If we have too much sodium or chlorine, we actually dehydrate ourselves. Potassium is also a big thing that we need. People that have heart disease, though, have a lot of trouble with potassium, so they have to watch potassium and sodium in their diet. And you can sort of see the breakdown between plasma, interstitial, and muscle, how those ions are in there. So the principal cation that we have is sodium. The principal anion is chlorine. And we also have some minor ones, which are for the cation potassium and for the anion hydrogen phosphate. Our intercellular fluid contains about 4 times as much protein as plasma, and you can sort of see that going on. This is a nicely coated chart here, and you can see that the sodium is high in both the plasma and the interstitial fluid, but the potassium is extremely high in our intercellular fluid. And the other two have very low potassium. Again, the interstitial fluid, very little protein. So as we look at the gas exchange for oxygen and carbon dioxide, we gain oxygen. Our red cells, like Bozeman was saying, is carried to the cell, to the interstitial tissue, our interstitial fluid, and able to exchange the oxygen for carbon dioxide, which is then carried out through our lungs. This is another way to look at it. You need to sort of know what's happening here and why the bicarbonate ion is important in carrying the CO2 away from our cells. CO2 does not just stay as CO2. When it hits a red blood cell, it does become a bicarbonate ion, and that's how we can get it into the plasma and out of the plasma. And we also have the chlorine ion that becomes part of this shift for us. As we're looking at the lungs and the heart in a little bit different look over here, we can sort of see what's going on with the trading of the oxygen with the CO2. Okay, so then we have what's known as oxyhemoglobin. That's when hemoglobin is combined with oxygen. Deoxyhemoglobin is when we don't have oxygen with the hemoglobin. And carbon hemoglobin is when you have the carbon dioxide. I should have a space between carbon dioxide, sorry, with the hemoglobin. So we have oxygen, the oxygen's released, then we have the deoxyhemoglobin, and then it's combined with the carbon dioxide to get the carbon there. So what's happening, the deoxygenated hemoglobin is non-planar, whereas the oxygenated one is planar. You can look at it a different way right here with the deoxyform and the oxyform. You can sort of see how it combines. Okay. Mm-hmm. So these ones are actually reverse of these ones. So this part is down below on the other side. Okay, so in summary, this is basically sort of like a cartoon model of what's going on in the red blood cells. So we have oxygen coming in from the lungs and being attached to a hemoglobin. The hemoglobin comes over, releases the oxygen. Then we have the carbon dioxide come back in, form the bicarbonate ions, and then through a reaction here, we end up getting the carbon dioxide out and back into the lungs to expel. Okay, so O2 pickup, O2 delivery, CO2 pickup, CO2 delivery. Okay. All right, so main steps. The oxygen partial pressure is higher than the LOV, basically the lungs, than the red blood pressures. As a result, the oxygen diffuses through. Inside the red blood cells, the oxygen reacts with the hemoglobin to form hemoglobin, oxyhemoglobin, and hydrogen ions, and an increase in pH because of the H+ ions as we pass through the lungs. Then, so I've broken down each of these parts. As we get to where we want the oxygen to be over, we release the oxygen, and then we gain the CO2, making the carbonate ions, and then we replace it with chlorine, and then proteins release the CO2. So, very last step. The enzyme is working so we can get the CO2 released from the bicarbonate, and out. So you can sort of see there's 6 steps there, but basically the big 4 is what you need to know. Okay, another way to look at it, again, probably seeing that I'm pounding this with a hammer to get it into your head and something that might be important. Here we have a performance-enhancing drug that is used to do different things. For instance, stimulate producing muscle or stuff like that. Problems with deciding on what's illegal and what some of the ethical questions that are up there. Why don't you take a look at them and just look at why things might be banned or what ethical questions are brought up. As you probably realize, there's a lot of things that used the right way can help people. For instance, steroids. People that have lung problems like asthma occasionally have to be put on steroids so that they can breathe. Often steroids are used to reduce swelling in people that have airway closures. But use of steroids over time can cause a lot of problems. So hopefully you took a chance and looked at that. So angioplasty is when we go in with a balloon into the arteries and we actually expand this balloon and we leave what's called a stent, and this is what a stent looks like. Then they release the balloon and pull it back out. Some symptoms that might cause somebody to go in for this would be chest pain, irregular heartbeat, shortness of breath, sleep problems, and fatigue. Causes are we build up plaque in our blood vessels from eating too many fatty foods and stuff like that, and that limits the amount of hemoglobin that can get through, therefore the amount of oxygen that can be delivered to the cells, and it leads to heart attacks and stroke and even death. So lifestyle changes are the main thing after they get the problem fixed. So angioplasty, this is where they widen it. They've had some problems with some of the stents in the past that they've collapsed or they've actually caused blockages when they partially collapse, and so there's been some lawsuits with that. But without it, they're dead anyway. So remember that we need to make sure that we understand delivery and accepting of CO2 and oxygen, and this is going over it again and again, and yes, I'm pounding it in your head, but you do need to know the shift that's taking place, how chlorine is affected in there, and how the bicarbonate ion is used. So how do we transport chemicals to cells? Blood flow through capillary, we have oxygen. We also have glucose that's very important, especially for diabetics. We have carbon dioxide that's coming out of the cells and urea that's out of the cells into the kidneys to be taken out of the system. In the Bozeman video, he talked about the pressure and how it's forced out and in. Osmotic pressure helps the liquid out here come back in here to help force chemicals out. You do have filtration. You have times when you have no net movement, and then you have reabsorption that's going to be taking place. Again, the reabsorption is usually with urea and CO2. The net movement out or the filtration coming out, we're looking at glucose being moved, at oxygen being moved, at ions and cations being moved to our body's cells. What is in urine? Urine is 2% urea, which is our ammonias or our nitrogens coming out of our bodies that we don't need anymore. It's got ammonia, sulfate, phosphates, chloride, magnesium, calcium, potassium, sodium, creatine, uric acid. All are part of urine, but most the part of the urine is 95% water. So doctors can tell really quickly if you're dehydrated because of the color of the urine and also because of the percent composition. It also has, if you have problems with your with diabetes, it'll also show proteins in your urine, which shouldn't be in the urine. Some other things that can be given off, things that they worry about, sugars, proteins, ketone bodies, bilirubin and bile, that tells that there's something wrong with the liver. Blood can say that there's infections. Stones, calcium stones, that there's problems with either the gallbladder and or the pancreas or the liver. So how hydrated am I? Like I said, the doctors can look at the color of the urine and be able to tell how hydrated you are. You've got to be careful. We talked about vitamins before, but especially the fatty ones. Remember that they do not pass through the urine. They stick in the fat, and they can cause a lot of problems. If you're taking a lot of water-soluble vitamins, they just pass through the urine and just make your urine darker color. In other words, you end up with a very expensive pee. Okay? Going forward, abnormal stuff that, again, can be found in urinary glucose, usually because you're taking too much sugary foods or you have diabetes. Proteins, again, it can be caused because you've been working out too hard and your body's actually breaking down your muscles is one of them. But it also can have problems with your kidneys, hypertension, a lot of different things like that. Pus, which would be white blood cells that shouldn't be coming out in your urine, and bacteria, that means you've got an infection. Red blood cells, that means you're bleeding somehow due to trauma or kidney stones or an infection. Hemoglobin, you've had some kind of anemia reaction. Bile, that's really important because that causes liver disease, or denotes liver disease, hepatitis, cirrhosis of the liver, things like that. Okay, so fluid and electrolyte imbalance. Our body composition is basically a lot water, and if we don't drink a lot of water, we're going to have problems. And you can see how much percent each of the things in our body has for water. For males, the minimum you should be drinking a day is 2.5 liters. For females, 2 liters. For children, 1 liter a day. So that's the minimum. As we look at this, you can actually drink too much and actually cause yourself to have problems because your body needs electrolytes to talk to the rest of your body. So total water, we basically, in a 70 kilogram person, we have 42 liters of water. And it sort of breaks down. I thought that was very interesting that we had that much water just running around in our body. In order for our intestines to work, we have to have water to move things through. So that sort of goes back there on that. So here's a little cartoon I thought was helpful. Homeostasis, a question of balance. So your acids versus your bases kind of things going on and what's happening. So acids produced by the body, metabolism, there we go, alter the internal environment of the body. Look out, here we come, below. Hey, watch it, you're going to cause an imbalance in my volume. Whoa, you're going to knock me off balance. So water and electrolytes have to be at a specific balance. Like I said, if you have too much water or not enough water, it can throw you either way. And you can sort of see on either side on the bottom what happens if I have too much of one or the other. So if I have too much water, I can actually end up in organ failure or disease processes. If I have too much electrolytes, I am going to have medical problems and I'm going to need to have some pharmaceutical stuff going on. Any imbalance in the body's fluids or electrolytes, it can cause a compensatory reaction for the body to try and remain balanced. It's just like if somebody comes and pushes you, you're trying to regain your balance. You don't want to fall. So the main thing that they try and do when somebody is going under a major trauma, they put an IV in. Why? To help keep them hydrated and to make sure that they maintain the electrolyte balance. They don't just put water in, right? It's a saline solution. It has electrolytes in it. So they have to worry about that. Too much acid can make the body work with, because the body only works within a very narrow range of pH. If I go too far above or below that, my system starts shutting down. My organs start failing. Most diseases cause an imbalance that can cause more problems than the disease itself. So just because my sugars are off because I'm diabetic, that's not the only thing that's going wrong. High blood pressure, you start losing capillaries, you start losing feeling in different places. Hydrogen is the first responder. So hydrogen helps us to maintain that pH balance. But we have 3 buffers to help us maintain the pH balance. We have a CO2 buffer, we have a bicarbonate buffer, and we have a phosphate buffer. And we already have gone through pH, and the higher the hydrogen, the lower the pH. The higher the pH number, the lower the H plus concentration. Now, just because our body itself has to maintain a specific pH, that doesn't mean that our body systems inside our body don't have different pHs. Our stomach is acid, right?
Someone messes up making saline solution.
Can cause death. Yeah, it can cause death. So we have to make sure that it's isotonic is what it means. What it's said is so that we don't put people into shock. Because if you put something in, for instance, I'll use an example that I had. I had to go in for surgery for some stuff, and I'm diabetic, but they had me go in. They had me fast all night, and they didn't get me into surgery till almost 5 o'clock, 6 o'clock the next day at night. And so my sugars were really, really low. And when they tested them, I was at 40, which is really, really, really bad. And I was starting to lose it. And so the doctor ordered glucose to be given. But instead of putting the glucose into my IV saline and letting it drip slowly, the nurse put it right into my vein. And it burned my vein. And caused it to die. So then they had to replace the IV and I had a hard vein for a long time before it was reabsorbed. So you have to be really careful with that kind of stuff. Okay, so you can see right here gastric juices, 1 to 3 pH, and that becomes a problem when people get ulcers because once that stomach lining is holding in those gastric juices, and when you get ulcers, those are basically sores inside your stomach that have gone through the lining of your stomach and now are outside the containment area. And so then that acid starts eating that sore until it goes all the way through. And then you have major problems. So you can sort of see most of the systems, though, are about 7. Urine is just between 5 and 6, but most of them are at about 7, and that's where we want to keep most things is between 7.3 and 7.5 is usually what they say. Okay, so fluid balance. I'm going to hit this over and over again. You've got to have the specific amount of water that you need. A lot of people that have heart disease are put on diuretics, which makes the water force the water through their system. So they call them water pills. So you can sort of read this. I'm not going to read this whole thing to you. But the important thing here is potassium and sodium, and this is sodium and potassium here. They are very, very important into keeping the water balance in our brain and our kidneys. And if you'll notice, if you start to get dehydrated, you start getting a fuzzy feeling. If you've ever been hiking for very long and you haven't taken water like you should, you'll start getting that fuzzy headache, hurts, and you get sick to your stomach, and then everybody's telling you to drink and you don't want to drink because it doesn't, I'm going to throw up. That's because you have a water imbalance. But if you drink, you'll actually feel better. Okay? So, going forward, make sure I didn't skip anything there. I like the cartoons because it helps me to remember things. So as we're looking at fluid volume, too much fluid going in with failure to eliminate. So this is where they use the water pills. Because if I have too much water coming in and I don't get rid of it, then I start drowning in my own fluid. Okay? So we lose some water as we breathe in and out. That's why we can breathe on glass when it's cold and we get the fog on it. Neurological changes, like I said, you get confusion, headache. You can actually get seizures if you get too high or low on water. Cardiovascular. You can have tachycardia. You can have higher blood pressure. That's why a lot of times with people with heart, they don't want their blood pressure going up. So they'll give them water pills to make sure they're getting the water through and they keep it down. Sodium concentrations can be decreased as well as osmolarity because there is more water than sodium, and the hematocrit will be reduced from the dilution of the water. Great minds think alike, so you try to reduce that. So here are two different things that you need to know. Okay, so hypo, and I never say this right, hyponatremia. All right, where did all the sodium go? So if we have some lethargy, headaches, confusion, apprehensions, seizures, coma, this is when our sodium is too low. Okay, low sodium is a result of drinking too much water, or I've lost sodium somehow by sweating too much. So this is something they worry about when kids are throwing up a lot and they're not drinking. When sports people exercise too much and do not rehydrate with more than just water, because they've lost the salt with their sweating and perspiration. So there are some situations you can see there. If you have diarrhea a long time, if you have vomiting, if they've taken too many diuretics, those are all things that can happen. On the dehydration, you have no water, no salt, or both. Okay, so you now are really, really, really dehydrated. And the saliva starts becoming really sticky, or their whole mouth will go dry and the lips will crack. It can also cause vomiting and diarrhea, believe it or not. And then you get worse. So the skin, you can pinch it and it'll stay pinched. It won't. So if you see a doctor pinch a baby's skin to see if they've been throwing up or having diarrhea a lot, it's to see if the skin will go right back. If it goes right back, they know they're not really dehydrated. But if it stays, they know they've got problems. Okay, average intake of water and output. So here's your intake. Just from breathing and doing stuff, just from breathing in the air, you'll get 10%. Foods will have about 30%, and beverages about 60% of what you intake a day. So 2,500 milliliters or 2.5 liters. Coming out, feces, 4%, sweat, 8%, just breathing, 28%, and then the urine is 60%. Okay? So here's your acid-base balance. Now, a lot of the diets want to put you in ketoacidosis, which is right before acidosis. They want you to be just this side of acidosis, but below a normal pH. Now notice the pH difference. Here's normal pH, here's acidosis, here's death. There's not a lot of difference in the pH. So if my buffer systems break down, I'm dead. Okay? This happens a lot on the other side too, when kids go away to college and they decide, I want to get into this sorority or fraternity, and you have to drink so much or do so much, they do these stupid things and they drink way too much. They put their body pH blood range out of where it should be, and they end up dead. So we have to be really careful, because on either side of the scale I can be dead. So once I hit 7.8, I'm dead. Once I hit 6.8, I'm dead. So be careful. We do have, like I said, 3 buffers in our system. We have the bicarbonate buffer. This is the most mobile. It moves around in your blood. It's your blood buffer. You have your proteins, especially hemoglobin or oxyhemoglobin. This is the powerful buffer. And then you have the phosphate buffer. And that only works about 5% of the total capacity, so it's very small compared to the other 2. This one is the big one. But you break a buffer and you're dead. So maintaining blood pH. We've got acid entering the system to combine with the bicarbonate ion to make carbonic acid. And we've got carbon dioxide exhaling as we get rid of that carbon dioxide or the carbonic acid. Remember, carbonic acid is very unstable, so once I get the carbonate ion with an extra hydrogen and make that carbonic acid, it quickly decomposes into water and carbon dioxide. Okay? It's sort of like combustion, but it's a little bit different because we didn't have oxygen on this side. Okay? So it is a decomposition reaction. We had to put the ions together first to get the main thing first, and then we can decompose it. Okay? So buffer systems in the body, again, we've got ICF, which is our phosphate buffer, and our protein buffer. And ECF include the protein buffer and the carbonic buffer. Remember, this buffer in the center is the big buffer. This one covers most of them. You can see it goes down to a hemoglobin buffer, amino acid buffers, and plasma protein buffers. So it includes 3 other things. That's our big buffer. Okay? The respiratory also can control pH. So if you have somebody that's hyperventilating, what do the doctor usually give them? A paper bag, right? Why? Because they don't want them to put more in. They want to get their carbon dioxide back in because they're putting too much acid in. And they're going to cause their blood to cause problems. So even though it looks like a real simple fix, it's an important one. So depending on what happens here, I've got to compensate so that when my H+, my generation of H+, which causes pH to increase or decrease as far as numbers, we can do that. Okay, so normal cycle. So slow respirations, I retain more CO2. I increase the pressure of CO2 in the blood. It stimulates the central chemical receptors, stimulates inspiratory muscles, increased respiration rate, removes CO2 from the body, decreases the pressure of CO2, decreases the chemoreceptors, then I've got a slow, so it's a cycle. As long as I'm breathing normal, we're good. Okay? Urinary control of pH. So, in other words, I need to get rid of the stuff in order for it to go away, basically. So my response to kidney acid-base imbalance is governed by the relative proton secretion and the HCO3, or the bicarbonate filtration. Because these 2 factors affect the rate of acid and alkali excretions. If the pressure of CO2 rises, protein secretion becomes dominant, and the kidneys excrete acid, raising the blood pressure, or blood pH. If the CO3, or bicarbonate ion pressure, rises, then the bicarbonate filtration increases and the kidney excretes alkali, reducing the blood pressure, blood pH. So it's sort of see what's going on here. Okay, so here's how we produce urine. So we've got glomerular filtration, we've got tubular reabsorption, we've got tubular secretion, and we've got excretion. We all have these little tubulars that go to the bladder, and we actually bring stuff in, filter it, it comes out into the tubule, and then the clean blood is given to the rest of the body through the renal vein. So here's a kidney, just a little teeny part of it again, sort of a little bit more explanation of what's going on. There's stuff that we want to keep, there's stuff that we want to get rid of. So what we want to get rid of comes out through the urine. But we have several of these loops that are going on to filter what we want to keep and what we don't want to keep. And you can sort of see the active transport is red. We're actively moving it out. Passive transport, it can go both ways. And secretion is what I'm trying to get rid of. So drugs and poisons and stuff like that. Okay, here's another little blip on Bozeman for you.
Hi, it's Paul Anderson, and in this video I'm going to go through the basics of the urinary system. The major organs in the urinary system are going to be the kidneys, and their major role is in waste excretion. They're cleaning our blood, and solid waste from the blood is eventually going to leave our body as urine. Now, in addition to doing that, they also regulate blood volume, blood pressure, blood pH. They regulate important electrolytes and metabolites in our body. The kidneys are incredibly important. Without them, you'll die unless you're hooked up to a kidney dialysis machine. But that's going to require going 3 times a week, 4 to 5 hours a day, hooked up to a machine just to clean your blood. Now, in addition to the kidneys, we also have other parts of the urinary system, including the ureter, the bladder, and the urethra. In males and females, the urinary system is essentially identical, except for the length of the urethra itself. Now, what's the role of the kidney? The role is to produce urine. From there, it's transported to the bladder through the ureters, and then from there it's stored and eventually conducted into the environment. That's how we lose this waste. Now, you might be thinking to yourself, what is urine? Well, urine is mostly water, so 90 to 95% of urine is going to be water, but the rest of it is going to be solid waste, both inorganic and organic. Organic waste like urea, uric acid, and inorganics like toxins and certain salts as well. If we look at the structure of the kidney, on the outside we're going to have the renal cortex. Renal simply means kidney. So we've got the outer layer of the kidney, and then on the inside we have the renal medulla. And then on the center we have the renal pelvis. This is going to be a hollow opening, and this is where all the nephrons are going to enter into. They're going to get rid of their urine, and that's eventually going to go through the ureter. Now if we look inside the kidney itself, we find the whole thing is just filled with blood vessels. Around 20% of cardiac output is going through the kidneys. So that's a massive amount of blood that's going through the kidneys. How does it do that? Well, it comes in through the renal artery, out through the renal vein, but there's a huge amount of surface area inside the kidneys itself. From there, we go into smaller arteries, and then arterioles and capillaries, and then eventually the blood is going to come out. But the important waste excretion is going to take place as we get to those center blood vessels. So let's zoom into that, and let's zoom into the functional unit of the kidney, which is going to be the nephron. So if we look at where these blood vessels are found, blood's going to flow into the nephron through the afferent arteriole, and then it goes into the glomerulus, or the glomerular capillaries. At this point, you essentially have a dead end. The blood is flowing in, and it comes to a dead end. That dead end is inside something called the Bowman's capsule. At this point, we're going to have filtration occurring. A lot of that blood plasma is squirting out of the capillary, and it's eventually going to move into the urinary system. From there, the blood goes through the afferent arteriole. And so at this point, we've got filtration taking place. This is where we're actually filtering the blood. Now, if you look at the blood vessels, they continue to go and wrap around the rest of the nephron, the peritubular capillaries, before they're eventually going to leave. What's going on all of this surface area is secretion and reabsorption. Secretion is when we're taking material that's in the blood that wasn't filtered out, but we're getting rid of that. And also there's some material in the filtrate, glucose, water, for example, that we want to reabsorb. So we're going to take that back into the circulatory system. So if we remove the circulatory system, now we can kind of see what that nephron looks like. First part's going to be the renal corpuscle right here. If we look at what's taking place there, that's where that filtration occurs. So at this point, we call this a filtrate. From there, it's going into a number of different renal tubules. The first one is going to be the proximal convoluted tubule. Proximal means close to the renal corpuscle. Convoluted means it's just folded over and over in many different dimensions. We're increasing the surface area there. What's going on at this place is that we're reabsorbing important material. We're reabsorbing solutes, water. We're taking that back into our circulatory system. From there, the renal tubules are going to flow down into what's called the loop of Henle. We have a descending limb of the loop of Henle, and during that, we're reabsorbing a lot of the water. And then as we have the ascending limb of the loop of Henle, we're reabsorbing a lot of that sodium and chloride, a lot of that salts are coming back into our body. If we look at where we are inside the kidney itself, as we go down into the loop of Henle, we've entered into that renal medulla. And if you think about what's going on as we move farther and farther down, we've set up a countercurrent exchange. What we're doing is we're increasing the salt levels as we move farther and farther down into that renal medulla. That makes it easier for us to take back more of that water in the descending limb of the loop of Henle and also in the collecting duct. From there, we're moving into the distal convoluted tubule and then into the collecting duct. If you think about where this collecting duct is going, you can see that we're getting a bunch of other nephrons that are connected to it as well. From here, it's eventually going into that center of the kidney, the renal pelvis, and eventually it's going to leave as urine. Now, what's going along in that distal convoluted tubule and the collecting duct is we have variable secretion and reabsorption of solutes and water. So in other words, sometimes we're getting rid of waste and sometimes we're taking that back into the body. Now a lot of this is under hormone control. So for example, a really important hormone is vasopressin or ADH, antidiuretic hormone. And what that's going to do is it's going to affect the distal convoluted tubule and the collecting duct itself. And what it does is it essentially shuts down the flow of water outside our body. And so we can get a signal, if we sense how much water there is in our blood, we can get a signal that means we have to hold on to that. Or we can have a signal that says we want to release that water and it's eventually going to leave as urine. If we look at where it goes, from here, all of that waste that comes out of the nephron is emptying out eventually into the pelvis, into the ureter, and it's stored in the bladder itself. From there, we can eventually conduct that to the environment. And so that's how the urinary system works. It's really simple. It's also really, really important, and I hope that was helpful.
Okay, so then we get into acidosis and keto and alkalosis. I cannot say that. Alkalosis. Okay, so alkalosis, you're kicking up the pH. The pH is becoming more alkaline. Acidosis, you're sliding down the pH scale and it's becoming more acid. As you do that, the difference between, so when your body fluids contain too much acid, it's known as acidosis. It occurs when your kidneys and lungs can't keep up with your body's pH in balance. Respiratory and metabolic, we'll go into those separately. It maintain a healthy weight and stay hydrated by drinking plenty of fuel. This is how you can balance that. On the other side, we have alkalosis, is a condition where you have more base. It's decreased carbon dioxide or increased bicarbonate levels in the blood. Type of alkalosis are respiratory, compensated, metabolic, hypochloremic, and hypokalemic. Again, it's staying a healthy diet. So causes. Yep. So causes, if we look at this, hyperventilation, there we go. When somebody gets anxiety and they start breathing way, way, way too fast, or if they're at a high respiratory, or sometimes it can be caused by pregnancy or fever, this is where we have what's known as respiratory alkalosis, where our pH goes up and our CO2 goes down. That's why we breathe into the bag. Okay, if we start with the other, which is alkosis, this is when somebody overuses antacids. Every meal they have antacids with it, because my stomach hurts or something like that. They lose gastric juices somehow through holes in their stomach or ulcers. They have taken too many diuretics, and they end up with high pH and a high amount of bicarbonate ion. So let's look at this first one. When we look at metabolic acidosis, some things that happen here. We've got headaches, we've got decreased blood pressure, we've got hyperkalemia, we've got muscle twitching, we've got warm, flushed skin, nausea, vomiting, diarrhea, changes in how they perceive things, confusion, and increased drowsiness. They are hyperventilating. Some causes that can happen here. Our ability of our kidneys to excrete acid or conserve base is compromised. Versus respiratory acidosis. This is hypoventilation. I can't seem to catch my breath. Rapid, shallow respirations. Low blood pressure, skin, they get sort of like a blue color to them, that's cyanotic. They have headache, they have an increased potassium, they're drowsy, dizzy, disoriented, muscle weakness, and you can see sort of how this works. And this is with the lungs. So acidosis is with the lungs, metabolic acidosis is with the kidneys. Okay, so the difference there.
Our next H word almost always gives people an unsettled feeling.
Can't do this anymore. It's over.
What do you mean it's over? You can't do this anymore. It can't be over.
I'm done.
How can you be done? We just started.
Does recurring hyperventilating cause long-term side effects?
Oh my goodness.
I like the way that question was presented.
I know. And interestingly, women tend to hyperventilate a lot more than men. Emotional stress, other things like physical stress, anxiety, panic attacks, fever, some medicines, asthma and emphysema can also bring this on, some rare cases of head injury. So there's a lot of things that can, do this. If it's persistent, you definitely need to speak with your doctor about it.
Well, and the question was, does hyperventilating over the long term cause health problems? The question is, why is it happening? And I see a lot of this, believe it or not, in the emergency department. Hyperventilating often does accompany panic attacks, etc. And when you hyperventilate, it has a true physiologic response in the body, which acutely is not necessarily good. So as you begin to hyperventilate, you're breathing too fast. As you're breathing too fast, your heart rate increases. As your heart rate increases, a lot of things are changing in your body because your heart's beating faster, you're breathing faster. What you're doing is you're breathing out too much CO2, too much carbon dioxide. So the carbon dioxide level drops and your pH level goes up. You can get some vasoconstriction, constriction of your blood vessels. What happens then? Tingling in your hands. You may start to feel tingling in your legs and your feet. And then, of course, as we saw in that tape piece, you can get very dizzy because as you're blowing off all that carbon dioxide, it does wreak havoc with what your pH should be in your bloodstream. If you continue to hyperventilate, you could even pass out. That's why you've seen it on airplanes. As people hyperventilate, they bring you a bag. And the idea is, as you're breathing out carbon dioxide, you're actually breathing some back in. And this is something that theoretically could work if you're having nothing but a hyperventilation episode.
In the ER now, if you make the diagnosis, you rule out heart problems, respiratory problems, you give them a brown paper bag.
You know what? I actually do. I try to do a little bit more of what Dr. Lisa is going to describe.
Yeah,
because
there's other
I'm not a big
things to
fan
do
of
with a
handing
paper
bags
bag.
to people and just saying, just keep breathing in the bag. You're good. I'll be back in an hour.
Really? Okay.
You know, you don't want someone to. But
There's other things
there
you
are
can
things
practice,
you can do.
like trying to blow, like you're blowing out a candle. Just put your two lips together and blow. Closing one nostril, and that may help as well. Breathe slowly, one breath every 5 seconds, and try doing the belly breathing. So breathing from your abdomen.
So a lot of just
In and out. Controlled breathing, exactly.
What's
But
your
we can't express
relaxation?
enough. If it's, you need to find the
Exercises.
problem. You need to check it with your doctor if it persists.
Okay, so let's go ahead and go forward here. Respiratory alkalosis. This is, remember, alkalosis. Now we're going the base side. We've got same kind of things going on, but he did talk about numbing and tingling. Metabolic. Whenever it says metabolic, you're working with the kidneys. Whenever it says respiratory, lungs. So metabolic, when I'm going to the base side, same sort of kind of things going on. So a lot of times they're treated the same way to get things under control. It's all about the breathing.
A sleep study is one of the key tests doctors use to diagnose a condition called obesity hypoventilation syndrome, or OHS.
So obesity hypoventilation syndrome is a condition where people with greater than ideal body weight perpetually underbreathe.
Dr. Eric Olson says OHS is more dramatic at night, but it's also present during the day. It can happen to people who are obese with a BMI of 30 or more because their bodies can't compensate for the stress of the extra weight. Oxygen levels go down and carbon dioxide levels go up. Over the short term, OHS, which is often accompanied by obstructive sleep apnea, causes poor sleep, headaches, daytime sleepiness, and a general feeling of being unwell.
Over the long haul, you start to get complications primarily related to the heart.
As oxygen levels drop, vessels in the lungs constrict, making it hard for the right side of the heart to pump blood from the extremities back to the lungs for oxygenation. Over time, the right ventricle becomes enlarged and eventually wears out, causing heart failure. If you're diagnosed with OHS, it's important to get on the right treatment, and that involves using a positive airway pressure device, either CPAP or a bi-level pressure device. CPAP, which is also used for sleep apnea, keeps the throat open when you sleep by providing continuous inward flowing air pressure. A bi-level device boosts the breath taken by the patient. The bigger the breath, the more oxygen goes in and the more carbon dioxide goes out. A sleep study can help determine the appropriate PAP device and settings.
So patients who start PAP therapy feel better very quickly.
Dr. Olson says you should see a healthcare provider if you're obese and have symptoms that include snoring, halted breathing at night, waking up at night, daytime drowsiness, swollen legs, or shortness of breath. The right treatment can help you get a better night's sleep and therefore a better quality of life. For the Mayo Clinic News Network, I'm Vivian Williams.
Okay, so that's the end of what I've got for you. I hope this little blip that I gave you plus the little worksheet that I gave you will help you do better on this last test. I didn't mean to make you fall on the last one. I was hoping that you wouldn't. Last year they didn't, so I was hoping you wouldn't either. But you did. So let's pull up our shirts, our shoes and socks and boots or whatever you want to call them and kick this last test in the butt. Okay, so we have Wednesday, test opens on Friday, and it's open till the following Thursday. Okay? Mm-hmm. Any questions? Yes?
How does blood lipid levels involve?
Say it louder.
How does blood lipid levels react?
So blood lipid are blood fats.
Blood lipid levels.
Yeah, so that's blood fats. Remember, lipids are fats. So if I have fats in my arteries, they're going to be clogging my arteries and causing it so that there's not as much transport of carbon dioxide and oxygen happening because the fats are taking that place. Yes? Yes, we were. Is everybody ready for it? Okay. Yes?
So I was reading the book, and they said it up there, but when you're hyperventilating, you do a paper bag.
Mm-hmm.
It says to not use plastic.
Right. Because paper bags will allow some of the carbon dioxide to be released because it's more of a mesh, where plastic is solid. And it also can cause suffocation. Okay? Any others?